It's becoming a bigger part of all of our practices. Thanks, Gene.
Thanks, John. Thanks, John, for having me. Thank you all for sticking in for the afternoon. Nothing like a nice, concise topic like reoperative heart surgery, but hopefully we can get through and maybe hit some of the highlights of some concepts I think that are important. There's no disclosures. Reoperations, I'm sure, for all of us are becoming more and more common. In 2010, 22% of the cases that we did at Ochsner were redos. In general, and not surprisingly, the patients are older, they're sicker, and they've accumulated many comorbidities since the time of their last operation. On top of that, the situation is compounded by the fact that frequently the patients are not enthusiastic about having another heart operation. Their cardiologists are frequently not enthusiastic about sending them for another heart operation. And so by the time we see them, you know, they're pretty far down the pathway of debilitation and end-organ injury, and that just makes the situation worse. And there's no free ones. You know, the redos are scrutinized for outcomes just as much as our other cases are. And it's a little bit dicey because it's not as straightforward as a primary operation. It's much more complex, and I'm not sure that the risk models necessarily do a great job of incorporating all the variables that account for the increased risk in reoperative patients. I think anytime you're considering embarking on a reoperation, it's important to completely evaluate the patient's heart. It doesn't matter if it's a person that had a mitral valve repair when she was 30 and now she's back and not in childbearing age and wants a mechanical valve. It's important to go through everything because mysterious things can happen, and if you don't look for them, you're not going to find them. For sure, we get left heart catheterizations on all women over 50 and all men over 45. If there's any question about their coronaries, you got to get an angiogram. The cardiology guys have tried to convince me to do CTA coronary studies. I have not bought into that. I think the gold standard remains the angiogram. And there can be stealth problems that can sneak up on you that if you don't look, you don't find out about. For example, in a reoperation on a patient that had a previous mitral replacement, we did an angiogram. She didn't have any symptoms, but she had a huge kink in her circ from where the guy before had almost caught it with a stitch in doing the mitral replacement. Well, it was nice to know about that. It was nice to know where that was to avoid that area at the time of the reoperation. I think all the patients need an echo. Surface echo is usually adequate. Many patients, though, have some question of their mitral valve pathology, whether it's the degree of the mitral regurgitation or the mechanism of their MR. And if there's any questions about that, I think a TE is necessary. If on the echo studies there are regions of akinesis, I think as we just saw in the cardiac MRI talk, a viability study is important. This is particularly crucial because if you're going to try to decide if you're going to dissect out the left side of the heart to place another graft over there, if it's all scar, there's no point. And so you're doing additional operating and additional risk for no benefit. So the viability studies are vital. If there's any question, you got to make sure you have conduit. It can be greater saphenous vein, it can be lesser saphenous vein, but you got to make sure you have conduit if you're going to be doing a coronary operation or if there's concomitant coronary disease and you're back for a valve operation. I think for bad ventricles, assessment of contractile reserve is also useful, and that can be done in a variety of ways. It's very important as well to take a look at the end organs. In particular, patients with long-standing heart failure can have significant end organ compromise. The liver, which, getting back to my earlier comment, isn't even accounted for or has just been accounted for in the most recent update of the STS database, but liver function plays a huge role in outcomes and is frequently overlooked. Renal function is pretty obvious. We all think about that. Pulmonary function is another important, I think, risk stratification tool, and their CNS function is important too. You know, a lot of times the family members will be pushing for the older person to have an operation. The older person will sit there quietly, and you don't necessarily get a great sense of just how sharp they are. But if you spend some time talking to them, if they're Parkinsonian, they'll generally do all right, I think, with general anesthesia and an operation. But even the ones that are, you know, kind of mildly to moderately demented, the operation really can be a major setback for the patients, and that's an important thing to consider when you're meeting with these families and talking about planning these reoperations. And then lastly, it's important to get a sense of their functional status. You know, just because all their labs look good doesn't mean that they can recover from the operation. And just because you can get them out of the operating room doesn't mean they're going to make any kind of meaningful recovery if they're severely debilitated or even bedridden. Getting back to the issue of hepatic disease, the guys at Virginia published this paper not long ago in Annals looking at the MELD score. The MELD score is a great tool for sorting out the degree of hepatic impairment, and it correlates really well with outcomes. This paper demonstrated that for tricuspid valve work. There was another paper from the Mayo that was in gastroenterology a couple of years ago that also did a really good job of laying out increasing operative risk as the MELD score increased. And the thing that's particularly frustrating about the liver is there's very little you can do about it if you get burned on this. It's extremely difficult to reverse hepatic insufficiency postoperatively. You can keep pounding away with the alpha agents and trying to maintain a blood pressure, but then their kidneys are going to fail, and there's just no good fallback position. So I think it's vitally important when you're assessing these patients to take a hard look at their liver, and if there's any question about their bilirubin being elevated or their INR being up, get the hepatology guys to see them. They usually don't have much to add, but occasionally they can help you figure out a way to transiently make them better so that you can operate on them. Obviously, there's some risks we can't change, and there's some risks we can. We've tried hard to withhold any medications that may compromise wound healing or the ability of the patients to recover. One thing I learned from John a long time ago is all the herbal supplements that begin with G tend to promote bleeding. So we get the patients to stop their ginkgo, we get them to stop their garlic, and we get them to stop their ginger. On the other hand, a lot of times we let them keep taking their Plavix. And I realize that seems contradictory, but so many of these patients have drug-eluting stents that have been recently placed. They'll have some 50% coronary lesion that on top of their AS, and their cardiologist will stent that thinking it's going to make them better, when of course it doesn't, because their AS is their primary driver of their symptoms. But then they're sent to you for reoperation with a fresh drug-eluting stent. And in many of those patients, we've let them just keep taking their Plavix. And what we've seen is what I would imagine you all have seen as well, is some people bleed like they're on Coumadin, and some people bleed like they're not on anything. I think the Plavix response is highly variable, but we have operated on many patients in the reoperative situation with them on Plavix rather than roll the dice on a fresh drug-eluting stent closing. Smoking cessation sounds good if you can get the patients to do it. We've not had much success with that. Control of hypertension, if exceptionally high. We've all, I'm sure, operated on patients with uncontrolled hypertension, usually in the setting of acute dissection. And it seems that the hypertensive patients, once you make them normotensive, there's a much higher incidence of delirium and confusion postoperatively. And so if you can control that hypertension beforehand, even if it's just for a few days or weeks, I think that can help alleviate some of those concerns. And then lastly, the treatment of anemia. It's unclear, it's a little chicken or the egg. Patients that get transfused more have worse outcomes, we all know that. But is it because they started out anemic or because they bled more? I don't know. But if there's a way to treat the anemia preoperatively, I think that's worth considering. Certainly if they're profoundly anemic, a gastrointestinal workup is a reasonable thing to consider beforehand. You'd hate to give them their heparin dose and then have them cut loose with a big GI bleed. We have not given EPO to the redo patients, typically because it's expensive and it's hard to get it paid for. We have done it with our Jehovah's Witness patients, but not so much in the redos. Some other things that are not so easy to do but can be worthwhile. It's a bitter pill for the patients to swallow, but if somebody's baseline creatinine is 4 and their GFR is 18 or 20, initiating dialysis before the operation, I think, can significantly modify their risks. It's much better to have someone on chronic dialysis, I think, even if it's only been for a week or two, and take them to the operating room than it is to acutely dialyze them in the immediate postoperative period. People have reported mortalities as high as 40% postoperatively for acute dialysis, and that's hard to sort out because a lot of those patients require acute dialysis because of a low output state, and as a result, other organs are impaired as well, and they are associated with bad outcomes. But I think in a patient with a preoperative, very low GFR, biting the bullet, and initiating hemodialysis beforehand makes for a much smoother postoperative course. And I think also it's worth admitting patients. I know it's kind of an old school concept. I mean, so many patients now, it's just absolutely forbidden for them to be in the hospital before the time of their operation. But certainly in patients with advanced heart failure, especially patients who are coming in for quasi-elective LVADs, that kind of a situation, we've been admitting those patients, putting in a swan, putting them on a little milrinone or a little dobutamine and a Lasix drip and trying to get them diuresed. A lot of them we put balloon pumps in as well, and I think that makes a huge difference, especially if these patients are coming to the operating room waterlogged, and then you're doing a redo operation in which it's going to take longer. The anesthesiologists are going to give them more fluid. They're more likely to get blood and blood products at the end, and if you can get rid of some of that water before you operate on them, certainly I think the outcomes are better. It's important to avoid minefields. I think it's absolutely imperative to get a CT scan on these patients, in particular if they've had a previous CABG and have live grafts. This is a little special something that somebody left behind for me. As you can see, that vein graft anteriorly, not only does it go right up to his sternum, it goes right up to his sternal non-union, which was particularly kind. And if you miss that one, this is the same patient, then there was this one that kind of came at it from the side, and as you can see, that vein approaches directly up and then is right behind the sternum there. And I just cannot believe that you can figure that out as well from an angiogram. I think the 3D spatial relationships between the sternum and the vein grafts is just very hard to sort out angiographically. I think the CAT scan with contrast is the only thing that can really allow you to do that. Another thing we've done too is get non-contrasted CT scans on the patients. In this particular instance, it illustrates that the aorta is close to but not directly abutting the sternum. But another very important thing that this shows is a degree of calcification in the ascending aorta. In this patient, there's not any, but in many patients, as we all know, there is. And I think the non-con CT can tell you a lot of important things when planning these operations. I think another thing important thing to consider is your options. Do you have to operate on them right away? I think the most common redo that we've been doing is aortic valve replacement after previous CABG. If the patients are really beat down and really deconditioned, we've had real good results with doing balloon valvuloplasty, sending the patients to cardiac rehab, and then operating on them 3 or 4 months after their valvuloplasty. It kind of drags things out, and the patients aren't happy about that, but with a better functional status going into the operation, they seem to do better with the overall course, and it makes it much easier to get them through it. And also, we got to consider the alternatives. You know, the percutaneous valve therapy trials have had early good results. I know we're going to hear more in detail about that tomorrow. But the risk-benefit of reoperation has to be weighed against other therapies too, not just the other therapies that may or may not be in your hospital. And if a patient's going to be high risk for redo, sternotomy, and AVR, it's worth considering signing them up for the partner trial or sending them to a center where there is a percutaneous aortic valve trial in play, because that may be a better choice for that particular patient. From an anesthesia standpoint, I think they all should have TE catheters, TE probes, and PA catheters. Of course, you got to have blood and plasma available. And if the RV is at all compromised, I think it's important to have nitric or some other PVR reducer available in order to get them off a bypass. You just don't want to get in a jam with a failing RV and not have anything to be able to do about it. I think some other things to think about when you're planning the operation: nobody benefits from half of the operation they need. You need to fix what all needs fixing. But also no one benefits from 3 halves of the operation that they need. If there's stuff there that doesn't need to be done, then don't do it. If you don't need to expose the left side of the heart, then don't expose the left side of the heart if you're just there for aortic valve or mitral valve work. Another thing I think to consider too, you know, we see a lot of patients with bad AS and moderate MR or moderate to severe MR. And what do you do about the MR? And it's a sick, old person, and you don't really want to do 2 cardiac incisions to address both valves. One thing to consider, and statistically, you know, 66% of them are going to get better when you relieve the obstruction at the level of the aortic valve. But one thing that can work out is to do an Alfieri stitch through the LVOT. You know, if you can get some creative ideas like that to address kind of dual pathology with 1 incision, that can make a big difference in these patients. It can shorten the operative time and still allow you to address what's wrong. The old mantra, replacing all the old veins just because you're there, I think is unrealistic. If the veins are patent, they're patent, and I don't replace patent veins. One of the most fundamental principles, I think, in reoperations is you absolutely have to be able to get on bypass at any time during the case, from right after the anesthesiologist induce until you're completely done. And there's a million reasons why that can happen, why you would have to get on bypass, but you have to be able to do that, and you have to have a plan for how you're going to do that, and everybody in the room has to know what that plan is. Frequently, we expose the axillary artery and use axillary cannulation for aortic work. A lot of folks are proponents of femoral cannulation. I am not particularly, but it's certainly a reasonable strategy. At the very least, on all reoperations, we place a wire in the common femoral artery and have percutaneous cannulas in the room in case there's a misadventure. Our need to crash onto the groin is less than 1%, but that doesn't mean it's 0%. And so it's important to have an extrathoracic bypass strategy. You always have to have access to vein. All kinds of things can happen. Coronary ostia can be obstructed. Old grafts can be damaged, and not prepping the legs in is madness. Myocardial protection is also extremely important in reoperations. I think coronary sinus catheter is mandatory. I rarely use topical cooling, but I think in reoperations it's worth doing because frequently, especially if the patients have their second round of coronary revascularization, if that's why they're there, they're going to have more diffuse native vessel disease. They're going to have more disease in their old vein grafts if that's what you're there for. And it's important to protect the heart as maximally as possible. And of course, the traditional no-touch technique when addressing the old veins. We've typically thought of reoperation in phases, and rather than kind of look at the whole thing and start worrying about what we're going to do about the mitral valve, we just kind of go through stepwise. And we establish our strategy for extrathoracic cannulation, get clear with everyone in the room, the perfusionists, the nurses, the anesthesiologist. Proceed with the sternotomy, the retrosternal adhesions. Intrapericardial dissection is limited only to allow cannulation in the chest. Then we cannulate, and then we start thinking about what we're going to do, what exposure we need for the specific procedure that we're there to do. There's a lot of different ways to skin a cat, but I think a safe maneuver that works reliably is to divide the wires, leave them in situ, and use the oscillating saw to divide the sternum, using the wires as a backstop. One thing I've seen people do that I would be very wary of is the technique of using the saw as kind of a crowbar to pry the sternum apart. I've seen some RVs get torn doing that. I would avoid that. But in the end, whatever you're comfortable with and whatever you're used to doing is acceptable. And if what you're doing leads to a lot of RV or aortic injuries, then it's important to find a different way to open the sternum. We use the mammary retractor. For the retrosternal dissection, it's just a lot more stable than an assistant and less likely to move when you least expect it. The course of the IMA will be known from the preoperative CT scan, and by staying very close to the bone, unless it's in an unusual position, you can generally avoid a patent mammary. In the left superior mediastinum, basically just stay away. There's very little over there that's going to be injured by traction when you put the sternal retractor in, and digging around in that area is only going to lead to an injury to the mammary. Generally, and again, these are broad generalizations, but I think if there's a patent lean to the LAD, you're less likely to incur an injury if you approach it from below than from the side. So if you start at the apex of the heart and identify the LAD and then work your way uphill until you identify the anastomosis, it's easier to follow that graft backwards in that manner than to approach it from the side, because it can just be very difficult to discern where it is amidst all the fat and whatnot in front of the PA. Redo CABG requires the most mobilization. As a result, there's a lot of opportunities for bleeding. We typically do not do sharp dissection for the intrapericardial dissection. We use the Bovie turned down around 15 or 20, which helps with our hemostasis at the end, and we've not seen any phrenic nerve injuries as a result of doing it that way. It is endlessly frustrating how difficult it can be to identify the target vessels in reoperations, and so I think it's important at your facility to have access in the operating room or immediately close by to be able to re-review the angiograms to help find the target vessels, know where to look for them. Another thing that comes up too, if the patient's had previous CABG, is there's just not enough room on the ascending aorta to base veins for the proximal anastomoses. And when that happens, a reasonable strategy is to put the new veins on the hood of the old veins. And if you have to, you can stack additional veins on top of those hoods. I've stacked, I think my record is 4 in a stack. But that's a reasonable strategy if there's just absolutely no spots for proximal vein grafts, whether it's from previous bypasses or calcium. For AVR, just kind of going through some different operations and coming up with some different things that I think are helpful in doing these reoperations. It's nice in the AVR setting to cannulate as distally as you can, maybe even with the origin of the innominate artery. It just helps to move the cannula out of the way. There's nothing wrong with completely transecting the aorta if it improves your exposure. Management of previous vein grafts is always interesting when doing AVR after previous CABG. Typically the one that gets in the way is a vein graft to the right. Usually you can come underneath the vein grafts to the left, but the vein graft to the right is often so high that if you go above it, your exposure to the valve is bad. You want to go below it, but it's in the way. I've divided it, I've replaced it, and occasionally, if it has enough slack in it, you can dissect it off of the right atrium and just kind of move it out of the way and work around it. But that's another good illustration, though, especially in this particular circumstance, of why it's vitally important to have access to vein. Because in the worst case scenario, you just replace that one. But that's an important thing to plan for and to account for when you're thinking of doing reoperation for AVR in a patient with previous CABG and a vein graft to the right. Generally, I think it's prudent to make your aortotomy distal to the old one. Most initial aortotomies are relatively low, and if you go more proximal than the old aortotomy, you run the risk of getting into the right coronary, which can be a moderate-sized problem. I think dissecting the old valve out with a freer elevator is a prudent thing to do. You're less likely to get an aortic injury than you would with sharp dissection, and old pledgets have to be removed. Redo mitral, ton of discussion could be generated about this, whether it's better to go from the front or from the side. We've typically done them through a sternotomy, but I do think by doing a transeptal approach and extending that out onto the dome of the left atrium, you get terrific exposure. You can see everything you need to see. You're less likely to leave them with a perivalvular leak due to poor suture technique, and you don't have to mobilize the heart as much. It's very difficult to get that heart to rotate if you've left the left-sided adhesions in place and you're trying to go through a left atriotomy in the typical position. Redo mitral valve repair. It gets talked about a little bit. It's very rarely seen. The few that I've been able to re-repair successfully have generally been because someone else put in a larger ring that was too big, and if you can downsize the ring, you can get away with it. Generally though, when someone before you has done leaflet work, at least in my experience, it's been very, very difficult to re-repair those valves, and in that circumstance, the best thing is to not spend a lot of hours fooling with it, but just to replace the valve. Redo tricuspid valve. I think for starters, think about not doing it. The reported mortality varies between 22 to 40%. It's a high-risk procedure because of the mechanism usually of their TR. It's RV dilation and failure. There's no data for it, but all the ones that we do them with the heart beating, just bicavally cannulate and open the atrium and never arrest them. I think you get better RV protection by never trying to stop the heart. Rigid rings will give you better outcomes, and we generally use 26 millimeter rings for the women and 28 for the men. One caveat to that is in heart transplantation, patients who've had their tricuspid valves damaged by biopsies fare much better, and I wouldn't hesitate to reoperate on one of them to repair a tricuspid valve, but that's obviously a different scenario than the typical TR patient. Lastly, for LVADs, we re-image all of our LVAD patients before listing them for transplant, and we get a non-con CT at the time they go back on the list. It makes it easy for the coordinators to remember. It makes sure that it gets done. And this one just illustrates that cannula is not in a bad spot, but it's nice to know that it's not directly behind the sternum. Also on the VAD patients, I think, especially if it's a patient that had ischemic cardiomyopathy and had previous CABG, with the crowding on the aorta, that outflow graft from the LVAD tends to sneak further and further out at the time of implant. And so people end up, because they don't really have any choice from the previous grafts and whatnot, the outflow graft ends up being pretty high on the ascending aorta. And so it's nice to cannulate the LVAD's axillary at the time of their transplant, because then you have more room for the clamp and you have more room to work with, because you want to get all that out when you put the new heart in. And I think that's all I got. Thank you.